Proton therapy advancements for head and neck cancer. Comparative analysis of proton therapy advancements for progressive head and neck cancer in the United States, Canada, United Kingdom, and Australia. James L. Mahan. Department of Medical Physics. 2026. Author note. James L. Mahan. 235 South Main Street No. 403. Ottawa, Kansas, 66067. United States of America. Price, $85 USD proton therapy advancements for head and neck cancer. Abstract. Proton therapy has emerged as a critical advancement in radiation oncology, particularly for the treatment of progressive head and neck cancers, HNC. Unlike conventional photon-based intensity-modulated radiation therapy, IMRT, intensity-modulated proton therapy, IMPT, exploits the Bragg peak phenomenon to deposit the majority of its ionizing energy directly at the tumor site, significantly reducing exit dose to surrounding critical structures. This paper presents a comparative analysis of proton therapy advancements across 4 English-speaking nations: the United States, Canada, the United Kingdom, and Australia, with specific focus on clinical infrastructure, measurement tools, treatment protocols, cause and effect relationships between radiation dose and organ at risk, or sparing, and patient outcomes in progressive HNC. Drawing upon 8 recent peer-reviewed articles from leading medical physics and radiation oncology journals, 2022 to 2025, this review identifies key similarities and disparities in access, clinical trial maturity, and therapeutic outcomes across these nations. Findings indicate that while the United States leads in proton center infrastructure and randomized controlled trial data, the United Kingdom has progressed with the landmark Torpedo Phase 3 trial. Australia is establishing its inaugural proton facility, and Canada remains the sole G7 nation without a domestic clinical proton center. Across all 4 nations, proton therapy demonstrates clinically meaningful reductions in acute toxicity, xerostomia, dysphagia, and feeding tube dependence, without compromising locoregional disease control. Standardized measurement tools, including the Common Terminology Criteria for Adverse Events, TCI, and the MD Anderson Dysphagia Inventory, MDATI, are essential for cross-institutional comparison. This paper concludes that international collaboration and equitable access to proton therapy infrastructure, proton therapy advancements for head and neck cancer, are essential to improving survival and quality of life outcomes for patients with progressive head and neck cancer globally. Keywords: proton therapy, intensity modulated proton therapy, head and neck cancer. IMRT, Bragg peak, oropharyngeal cancer, radiation oncology, medical physics, proton therapy advancements for head and neck cancer. Comparative analysis of proton therapy advancements for progressive head and neck cancer in the United States, Canada, United Kingdom, and Australia. Introduction. Head and neck cancers, HNC, represent the 7th most common malignancy worldwide, with nearly half of affected patients succumbing to their disease. Bala et al., 2024. The anatomical complexity of the head and neck region, which encompasses critical structures including the salivary glands, spinal cord, brainstem, cochlea, oral cavity, and swallowing musculature, renders radiation therapy uniquely challenging in this patient population. Conventional intensity modulated radiotherapy, IMRT, and its volumetric modulated arc therapy, VMAT, variants have significantly improved dose conformality over older photon techniques. However, IMRT's multi-angled photon fields inevitably deposit a diffuse low-dose bath to surrounding healthy tissues, producing dose redistribution to uninvolved structures and contributing to debilitating late toxicities. Lillo et al., 2024. Proton therapy, PT, offers a fundamental physical advantage through the Bragg peak phenomenon, wherein protons deposit the vast majority of their ionizing energy at a precisely defined tissue depth before stopping entirely, thereby producing minimal exit dose, NUTS-ETAL. 2022, Intensity Modulated Proton Therapy, IMPT, also known as pencil beam scanning proton therapy, exploits this principle to generate highly conformal dose distributions that simultaneously deliver therapeutic doses to tumor target volumes while sparing adjacent organs. At risk, ORs. For progressive HNC, in which tumors frequently reside in immediate proximity to the parotid glands, mandible, spinal cord, and pharyngeal constrictors, the dosimetric advantages of IMPT over IMRT are particularly compelling. Frank et al., 2024, Lee et al., 2023. Proton therapy advancements for head and neck cancer. Despite the biophysical rationale for proton therapy in HNC, global access to this technology remains highly unequal. The United States houses the largest number of clinical proton facilities worldwide, supporting multiple Phase 3 randomized controlled trials. The United Kingdom has pursued NHS-funded proton therapy through dedicated national centres and its Torpedo trial. Australia has recently completed construction of the Australian Bragg Centre for Proton Therapy and Research, representing a transformative development for Australasian cancer care. Canada, remarkably, remains the only G7 nation without an operational domestic clinical proton facility, requiring patients to travel abroad for treatment. Gorayski and Saran, 2024. Canadian Medical Association Journal, 2019. This paper provides a systematic comparative analysis of proton therapy advancements for progressive HNC across these four nations, organized around 5 key domains. 1. Measurement tools employed in clinical assessment. 2. The etiological and clinical rationale for proton therapy in HNC. 3. The purpose and indications for IMPT. 4. Treatment protocols and delivery strategies. And 5. Conclusions synthesizing global trends, disparities, and future directions in proton therapy for this patient population. Measurement tools in proton therapy for head and neck cancer. The rigorous assessment of treatment efficacy and toxicity in proton therapy for HNC depends upon standardized, validated measurement instruments applied consistently across clinical and research settings. These tools enable cross-institutional and international comparison, and are essential to the evidence base informing clinical policy across the United States, Canada, the United Kingdom, and Australia. Dosimetric assessment proton therapy advancements for head and neck cancer. Dosimetric measurement underpins all proton therapy planning and quality assurance. Treatment planning systems such as RayStation, Research Laboratories, Stockholm, Sweden, are used across international centers to calculate pencil beam scanning proton dose distributions. Bridging the Proton Gap, 2025. Dosimetric endpoints for OR sparing including mean dose to the parotid glands, mean oral cavity dose, spinal cord maximum dose, and cochlear dose are systematically evaluated using the dose volume histogram, DVH, framework. Studies by Lillo et al., 2024, demonstrate that proton plans deliver statistically significant reductions in mean OR doses compared to IMRT plans in nasopharyngeal and oropharyngeal cancer, with up to 50% reductions in mean parotid dose achievable in selected cases. A critical parameter in proton therapy dosimetry is the normal tissue complication probability, NTCP, model, which translates dose volume parameters into predicted probabilities of clinically meaningful toxicity. Anti-CP models for xerostomia and dysphagia are widely used in model-based selection of patients who stand to benefit most from proton therapy compared to IMRT, BALA et al., 2024. In the United Kingdom, the NHS Proton program applies anti-CP-based comparative planning to prioritize patients for IMPT funding, Price et al., as cited in NUTS et al. 2022. Clinical toxicity measurement. The common terminology criteria for adverse events, TCI, currently in version 5.0, provides the standardized physician-assessed grading scale for radiation-related toxicities. Applied across all 4 nations examined in this review. TCI grades range from 1, mild, to 5. Death, with grade 3 or above designating severe, clinically significant events. In the multi-institution MD Anderson Phase 3 trial, TCI was the primary toxicity instrument for grading acute adverse events, with IMPT demonstrating significantly reduced rates of grade 2 or higher proton therapy advancements for head and neck cancer. Acute toxicities including mucositis, dermatitis, and esophagitis compared to IMRT, Frank et al., 2024. Physician-assessed toxicity scales are complemented by patient-reported outcome, PRO. Instruments that capture the patient's subjective experience of treatment-related morbidity. The MD Anderson Dysphagia Inventory, MDATI, is a validated 20-item questionnaire assessing the emotional, functional, and physical dimensions of swallowing-related quality of life, and has been applied across U.S. and international HNC trials, Chen et al., 2025. The University of Washington Quality of Life Questionnaire version 4, UW-CAL v4, and the European Organization for Research and Treatment of Cancer, EORTC, QLQHN 35 Module R. Additional validated PRO tools used in UK and European proton therapy trials, including Torpedo, Kiev et al., 2024. Oncologic outcome measurement. Disease control endpoints standardized across international HNC proton therapy trials. Include overall survival, OS, progression-free survival, PFS, locoregional control, LRC, and disease-free survival, DFS, all estimated using the Kaplan-Meier method. In the landmark MD Anderson Phase 3 trial, a median follow-up of 3 years demonstrated PFS rates of 83%. IMPT, versus 83.5%, IMRT, confirming statistical non-inferiority of proton therapy for disease control, Frank et al., 2024. Feeding tube dependence measured as the proportion of patients requiring enteral nutrition at treatment completion and defined time points serves as an additional clinically meaningful endpoint. In the Phase 3 U.S. trial, IMPT significantly reduced feeding tube dependence at treatment completion relative to IMRT, representing a meaningful functional benefit for progressive HNC patients, Frank et al., 2024. Cause, the clinical rationale for proton therapy in progressive head and neck cancer. Proton therapy advancements for head and neck cancer. The biophysical and epidemiological causes underpinning the adoption of proton therapy for progressive HNC are multifactorial, encompassing the unique physical properties of proton beams, the evolving epidemiology of HNC, the long-term survivorship burden of radiation toxicity, and the limitations of photon-based radiotherapy at its current technological frontier. Physical properties of protons and the Bragg peak. Protons are positively charged particles that, unlike photons, deposit energy in tissue. According to the Bragg curve, characterized by a sharp peak of maximum ionization at the end of the proton's range, Lillo et al., 2024. This phenomenon, the Bragg peak, results in negligible exit dose beyond the tumor target, in stark contrast to photon beams that continue depositing dose throughout the depth of the patient. In clinical practice, the spread-out Bragg peak, SOBP, is formed through energy modulation to conform dose to the three-dimensional extent of the tumor volume, past, present, and future, 2020. The clinical consequence of these physical properties is that IMPT plans consistently demonstrate significant reductions in dose to ORS. Compared to even the most advanced IMRT techniques, a finding reproduced across dosimetric studies in oropharyngeal, nasopharyngeal, and paranasal sinus HNC, NUTS ETAL, 2022, Lillo ET. 2024. Epidemiological drivers, HPV-associated oropharyngeal cancer. The epidemiology of HNC has shifted substantially over the past 2 decades, with human papillomavirus, HPV, associated oropharyngeal squamous cell carcinoma, OPSC, now representing the predominant HNC etiology in high-income nations including the United States, Canada, the United Kingdom, and Australia, NUTS ETAL, 2022. HPV-positive OPSC is characterized by substantially improved prognosis relative to HPV-negative disease, producing an expanding cohort of long-term survivors who bear the late toxicity burden of curative proton therapy advancements for head and neck cancer, chemoradiotherapy across decades of life. These patients are particularly vulnerable to radiation induced xerostomia, dysphagia, mandibular osteoradionecrosis, and neurocognitive impairment. Toxicities that are meaningfully mitigated by the superior or sparing of IMPT, Frank ETAL. 2024, Chu ETAL, as cited in Bala ETAL, 2024. The long-term survivorship implications of HPV associated OPSC thus represent a compelling cause for the adoption of proton therapy in this patient population. Limitations of advanced photon radiotherapy. While IMRT and VMAT have substantially improved dose conformality compared to conventional three-dimensional conformal radiotherapy, these photon-based techniques are constrained by the physics of electromagnetic radiation. IMRT's multi-field approach produces a low-dose path to uninvolved tissues including the posterior cranial fossa, contralateral parotid glands, submandibular glands, oral cavity, and larynx that contributes to fatigue, xerostomia, and swallowing dysfunction, Lillo ETAL, 2024. The technological advances in photon planning are approaching the physical limits imposed by photon physics, providing a fundamental cause for the pursuit of proton and other particle-based radiotherapy modalities for progressive HNC. Bala ETAL, 2024. Reirradiation for recurrent disease. A particularly compelling cause for proton therapy in progressive HNC is the reirradiation scenario, retreating patients who have previously received full-course radiotherapy and have experienced locoregional disease recurrence. In this setting, the cumulative radiation dose to previously irradiated normal tissues can produce catastrophic late toxicities including carotid blowout, pharyngocutaneous fistula, and fatal hemorrhage. Lee ETAL, 2023, evaluated proton therapy reirradiation for recurrent head and neck squamous cell carcinoma at Memorial Proton Therapy Advancements for Head and Neck Cancer, Sloan Kettering Cancer Center, demonstrating that IMPT-based reirradiation achieves meaningful locoregional disease control while limiting high-dose re-exposure to critical structures that would be prohibitively risky with photon reirradiation. This represents a progressive indication uniquely enabled by the dosimetric characteristics of proton therapy. Purpose of proton therapy for progressive head and neck cancer. The purpose of proton therapy in progressive HNC is defined across 4 interrelated therapeutic objectives: maximizing tumor control, minimizing treatment-related toxicity, improving patient-reported quality of life, and enabling treatment in scenarios not safely achievable with photon radiotherapy. Tumor control with reduced toxicity. The primary therapeutic purpose of IMPT in progressive HNC is to deliver tumoricidal radiation doses to target volumes including the gross tumor and electively treated regional lymph nodes while simultaneously limiting dose to adjacent ORs below established tolerance thresholds. The Phase 3 randomized controlled trial led by Frank et al., 2024, at MD Anderson Cancer Center established that IMPT achieves this dual purpose with high fidelity. Disease control outcomes were statistically non-inferior to IMRT, while acute grade 2 or higher toxicity rates were significantly reduced, including feeding tube dependence and severe weight loss. The Lancet publication of these data in late 2025 represented a watershed moment for the field, providing level 1 evidence that proton therapy has both survival benefit and quality of life. Improvement in advanced oropharyngeal cancer, MD Anderson Cancer Center, 2025. Xerostomia and dysphagia mitigation. Xerostomia, chronic dry mouth resulting from radiation injury to the major and minor salivary glands, and dysphagia resulting from pharyngeal constrictor damage are among the proton therapy advancements for head and neck cancer. Most prevalent and functionally debilitating late toxicities of HNC radiotherapy. The explicit purpose of proton therapy in this context is OR sparing that reduces the incidence and severity of these toxicities. Chen et al., 2025, in a longitudinal Dutch cohort study, demonstrated that HNC patients treated with proton therapy experienced a predictable pattern of acute utility decline at treatment completion with substantial recovery within 6 months, and that toxicity correlations, particularly between xerostomia and dysphagia, were significant determinants of health utility. These findings underscore the purpose of proton therapy in minimizing the toxicity burden that compromises long-term patient function and quality of life. Treatment de-escalation in HPV-positive disease. An emerging and clinically important purpose of proton therapy in progressive HNC is its role in enabling treatment de-escalation strategies for patients with HPV-positive OPSC. The excellent prognosis of this patient population has prompted investigation of reduced radiation dose and field size in HPV-positive, low smoking history patients. Proton therapies. Superior normal tissue sparing provides a favorable platform for de-escalation, as the dosimetric margin of safety is greater with IMPT than with IMRT when elective nodal volumes are reduced. Lillo et al., 2024, Nutz et al., 2022. This represents a purposeful application of proton therapy that extends beyond traditional indications to reshape the therapeutic approach to HPV-driven HNC. Immune enhancement and combination therapies. An emerging purpose of proton therapy in progressive HNC is its potential immunogenic advantage compared to photon therapy. Preclinical and early clinical evidence suggests that the distinct linear energy transfer (LET) profile of proton beams may activate anti-tumor immune responses more effectively than conventional photons, potentially enhancing the efficacy of proton therapy advancements for head and neck cancer. Concurrent immunotherapy agents such as programmed death ligand 1, PDL1, checkpoint inhibitors, Lillo et al., 2024. While randomized clinical evidence for this combinatorial purpose is nascent, its theoretical and preclinical basis is compelling, particularly for patients with progressive or recurrent HNC in whom conventional chemoradiotherapy has failed. Proton therapy advancements by nation. United States. The United States possesses the world's most mature proton therapy infrastructure for HNC, encompassing more than 40 operational clinical proton facilities as of 2024 and a robust clinical trial program. The MD Anderson Cancer Center in Houston, Texas, stands as the preeminent U.S. proton therapy center for HNC, having treated more than 573 HNC patients. With proton therapy between 2006 and 2018 in prospective institutional studies, with favorable disease control and toxicity outcomes reported across a multi-disease site cohort, Garden et al. 2021, as cited in NIDS et al. 2022. The landmark U.S. contribution to the evidence base is the multi-institution Phase 3 randomized controlled trial led by Frank et al. 2024, which enrolled patients with locally advanced oropharyngeal carcinoma at MD Anderson and collaborating institutions. This trial demonstrated that IMPT was statistically non-inferior to IMRT in progression-free survival. 83% versus 83.5% at 3 years, while achieving significantly reduced feeding tube dependence and acute toxicity burden. The publication of full trial data in The Lancet in December 2025 established Level 1 evidence supporting IMPT as standard of care for advanced oropharyngeal cancer, representing a milestone for U.S.-led proton therapy research, MD Anderson Cancer Center, 2025. The American Society for Radiation Oncology, ASTRO, model policy supports proton therapy advancements for head and neck cancer. Proton therapy reimbursement for advanced HNC, reflecting the established indications in the U.S. clinical and payer landscape. Additionally, JAMA Network Open published a 2023 evaluation of proton therapy reirradiation for recurrent HNSCC by Lee et al. 2023, at Memorial Sloan Kettering Cancer Center, demonstrating the clinical feasibility and oncologic utility of IMPT-based reirradiation for this high-risk progressive disease scenario. These data illustrate the breadth and maturity of U.S. proton therapy research for HNC across both definitive and salvage treatment settings. United Kingdom. The United Kingdom's National Health Service, NHS, has pursued a deliberate, centralized approach to proton therapy provision for HNC. NHS England established dedicated high-energy proton beam therapy centres at University College London Hospital and the Christie Hospital in Manchester, funded through a national programme that initially prioritised pediatric and central nervous system indications before expanding to adult HNC, Kiev et al. 2024. The cornerstone of UK proton therapy evidence for HNC is the Torpedo trial of proton versus photon therapy for risk-adapted treatment of oropharyngeal cancer, Phase 3 randomized controlled trial. Torpedo is the first UK randomized clinical trial comparing IMPT to IMRT for locally advanced OPSC, enrolling patients across 16 UK centres between 2020 and 2023, Kiev et al. 2024. The trial enrolled 205 patients randomized 2:1 to IMPT, N equals 136, versus IMRT, N equals 69, with co-primary endpoints encompassing physician-assessed functional measures and patient-reported outcomes. Torpedo demonstrated no statistically significant difference in late patient-reported physical side effects or quality of life between the two modalities, a finding that partly reflected unexpectedly favorable contemporary IMRT proton therapy advancements for head and neck cancer performance, though the trial provides important Level 1 data for HNC proton therapy in the UK. Context, ASCO Post, 2025. Notably, Torpedo included extensive radiotherapy quality assurance training and a comprehensive translational research component incorporating imaging data, physics data, blood, and tissue samples to inform future patient selection for IMPT. British Dental Journal's 2022 review of recent advances in HNC oncological management highlighted proton therapy alongside MR-guided adaptive radiotherapy as the leading technological innovations being integrated into UK radiotherapy practice to minimize dose to critical structures and reduce oral and swallowing toxicities. Nature, 2022. The NHS model of centralized provision and national trial infrastructure represents a distinctive approach to evidence generation in the UK system. Canada. Canada occupies a paradoxical position in the international proton therapy landscape. It is the only G7 nation without an operational domestic clinical proton beam therapy facility. Canadian Medical Association Journal, 2019, Bridging the Proton Gap, 2025. Canadian patients requiring proton therapy for HNC and other indications must travel to U.S. proton centers for treatment courses that typically span 6 to 8 weeks, presenting substantial logistical, financial, and personal burdens. Provincial health authorities, including Alberta Health Services and Cancer Care Ontario, provide funding for out-of-country proton therapy referrals. For approved indications, including select HNC and base of skull tumors, however, access remains inequitable across provinces and patient demographics. Alberta Health Services, 2023. The absence of a domestic Canadian proton facility has prompted institutional innovation. Bridging the Proton Gap, 2025, published in PMC, described the first comparative proton consultation service in Canada, retrospectively reviewing 55 patients' proton therapy advancements for head and neck cancer. Referred from 6 provinces and 11 institutions between June 2020 and December 2024. This service generated pencil beam scanning proton plans in ray station and demonstrated statistically significant dosimetric reductions in cranial and thoracic OR parameters with proton therapy, providing Canadian oncologists with comparative dosimetric data to support out-of-country referral decisions. The Canadian Agency for Drugs and Technologies in Health, CADTH, Health Technology Assessment concluded that a single domestic proton unit is expected to save healthcare payers $12.9 million over a 10-year horizon compared to continued out-of-country referrals. Canadian Medical Association Journal, 2019. For HNC specifically, the incremental cost-effectiveness ratio of proton therapy compared to IMRT has been estimated at $4,254 to $143,229 per quality-adjusted life year. QALY, depending on the study and radiation technique, generally below the commonly accepted willingness to pay threshold of $150,000 per QALY, Canadian Medical Association Journal, 2019. These health economic data, combined with the dosimetric evidence and the growing clinical evidence base, have sustained advocacy for domestic Canadian proton therapy infrastructure, with several planning initiatives in British Columbia and Ontario as of the mid-2020s. Australia. Australia's proton therapy trajectory mirrors Canada's historical position of relying on international referrals, but with a decisive recent development, the near completion of the Australian Bragg Centre for Proton Therapy and Research, ABC, in Adelaide, South Australia. Operated through the South Australia Health and Medical Research Institute, SOMRI, in partnership with the Royal Adelaide Hospital and the University of South Australia, Goreyski and proton therapy advancements for head and neck cancer. Saran, 2024. The ABC represents Australia's first high-energy clinical proton facility and marks a transformative expansion of cancer care capability in the Australasian region. Goreyski and Saran, 2024, in an editorial published in the Journal of Medical Radiation Sciences, highlighted the precision and potential of particle therapy in reducing long-term side effects, particularly for pediatric and rare cancers, while acknowledging the potential for expanding indications to include HNC and reirradiation scenarios consistent with international standards and evidence. The authors noted that the likelihood of a significant near-term broadening of indications beyond pediatric and rare cancers is constrained by cost and access considerations, underscoring the challenge of translating the clinical evidence base for HNC proton therapy into routine practice in a nation with geographically dispersed population centers. The Australian experience of patients traveling overseas for proton beam therapy was examined in a retrospective interview study by Skelton et al., 2024, published in the Journal of Medical Radiation Sciences, which documented the substantial personal and financial toll of international proton therapy referrals for HNC patients whose treatment courses typically span 5 to 7 weeks and involve concurrent chemotherapy. International referrals represent a particularly burdensome pathway that the ABC is designed to obviate. The establishment of a consumer advisory group at the ABC, described by Penfold et al., 2024, reflects Australia's commitment to patient-centered proton therapy development aligned with equity principles for First Nations and Torres Strait Islander communities, who face the greatest disadvantage from distance to specialized cancer care. Treatment protocols and delivery strategies in proton therapy for progressive head and neck cancer. Proton therapy advancements for head and neck cancer. The treatment of progressive HNC with proton therapy involves a sophisticated integration of immobilization, imaging, treatment planning, delivery, and adaptive management strategies that are evolving rapidly across US, UK, Canadian, and Australian institutions. Patient immobilization and image guidance. Precise patient immobilization is paramount in proton therapy for HNC given the sensitivity of proton range to tissue density changes along the beam path. Custom thermoplastic masks covering the head, neck, and shoulders are standard, frequently combined with dental prostheses to reduce oral cavity air gaps that introduce proton range uncertainty. Daily image guided radiation therapy, IGRT, using KV cone beam CT or CT on rails is employed at major proton centers to verify patient positioning and detect anatomical changes requiring replacanning. Lane et al., as cited in Kiev et al., 2024. Adaptive proton therapy in which treatment plans are modified mid-course to account for tumor regression and anatomical change is an area of active development at leading U.S. centers including MD Anderson and Massachusetts General Hospital, Past, Present, and Future, 2020. Intensity modulated proton therapy planning. IMPT for HNC is delivered via pencil beam scanning, in which a narrow proton beam is magnetically deflected across the target volume in a raster pattern, with energy modulation providing depth control. Simultaneous integrated boost, SIB, techniques deliver differential doses to high-risk and low-risk target volumes within a single treatment session, improving efficiency and dose conformality. Typical dose prescriptions for definitive chemoradiotherapy in locally advanced OPSC are 70 GY, relative biological effectiveness, RBE, to the primary tumor, and involved nodes over 35 fractions, with elective nodal regions receiving 56 to 63 GY, RBE. Frank et al., 2024, Lillo et al., 2024. The relative biological effectiveness of proton beams is proton therapy advancements for head and neck cancer. Conventionally assumed at 1.1 relative to photons, though emerging evidence for variable RBE, particularly at the distal edge of the Bragg peak, is an active area of radiobiological research, with implications for clinical proton dose prescription, past, present, and future, 2020. Concurrent systemic therapy. For locally advanced HNC, proton therapy is most commonly delivered in combination with concurrent platinum-based chemotherapy, typically cisplatin 100 mg per square meter every 3 weeks, or weekly carboplatin/paclitaxel for cisplatin-ineligible patients. The Phase 3 MD Anderson trial employed concurrent cisplatin with IMPT or IMRT, confirming the safety and feasibility of combining full-dose chemoradiotherapy with proton beam delivery, Frank et al., 2024. In the Torpedo trial, UK patients received concurrent cisplatin with either IMPT or IMRT, ensuring comparability of systemic therapy across randomized arms, ASCO Post, 2025. Immunotherapy. Combinations with proton therapy represent an emerging frontier, with early phase trials ongoing. In the United States, evaluating PD-1/PD-L1 inhibitors concurrent with IMPT for locally advanced and recurrent HNC, Lillo et al., 2024. Proton therapy in the reirradiation setting. Progressive HNC patients with locoregional recurrence after prior radiotherapy represent a uniquely challenging clinical scenario in which proton therapy's dosimetric advantages are most critical. Lee et al., 2023, described proton reirradiation protocols at Memorial Sloan Kettering Cancer Center in which IMPT was delivered to previously irradiated target volumes, using highly conformal pencil beam scanning techniques that minimized cumulative dose to the carotid arteries, spinal cord, brainstem, and pharyngeal constrictors. Dose prescription in the reirradiation setting is highly individualized, reflecting the prior cumulative dose, the volume of recurrence, and the patient's performance status and comorbidities. Proton reirradiation proton therapy advancements for head and neck cancer represents one of the most clinically compelling applications of proton therapy in progressive HNC, as it enables potentially curative salvage radiotherapy in patients for whom photon reirradiation would pose unacceptable cumulative toxicity risk. Conclusion. This comparative analysis of proton therapy advancements for progressive head and neck cancer across the United States, Canada, the United Kingdom, and Australia reveals a field in dynamic evolution, characterized by mounting level 1 clinical evidence, expanding global infrastructure, and persistent disparities in access and reimbursement. The biophysical advantages of IMPT, particularly its Bragg peak dose distribution, superior or sparing, and minimal exit dose, provide a compelling rationale for its application in progressive HNC, where the anatomical complexity and long-term survivorship of the patient population impose substantial toxicity burdens with conventional IMRT. The United States has achieved the most advanced state of proton therapy clinical evidence for HNC, culminating in the Phase 3 MD Anderson trial published in The Lancet in 2025, which established Level 1 evidence for IMPT survival benefit and quality of life superiority in advanced oropharyngeal cancer. The United Kingdom's Torpedo trial has provided the first UK randomized HNC proton data, demonstrating safety and feasibility through a rigorous national trial infrastructure. Australia's establishment of the Australian Bragg Centre marks a watershed in Australasian proton therapy capability, though the practical expansion of HNC indications will require sustained investment and workforce development. Canada's continued absence of a domestic proton facility represents the most significant equity and access gap in the global HNC proton therapy landscape, with health economic analyses consistently supporting investment in domestic infrastructure. Proton therapy advancements for head and neck cancer. Standardized measurement tools including TGI physician-assessed grading, MDOTI and EORT-QLQHN 35 patient-reported outcomes, Kaplan-Meier oncologic endpoints, and anti-CP dosimetric models are essential for valid cross-institutional and international comparison of proton therapy outcomes. Adoption of harmonized outcome reporting frameworks across US, UK, Canadian, and Australian institutions will be critical to the ongoing evidence synthesis that informs reimbursement policy, clinical guidelines, and patient selection for IMPT. Future directions in proton therapy for progressive HNC include adaptive proton therapy, with mid-treatment replacing flash proton therapy delivering ultra-high dose rates with potential normal tissue sparing, variable RBE-weighted treatment planning, and integration with immunotherapy for combined radiobiological and immunogenic tumor control. International collaboration between US, UK, Australian, and Canadian proton centers will be essential to powering the multi-center randomized trials needed to validate these emerging strategies for the progressive HNC patient population. The goal is unambiguous: to deliver the most effective, least toxic radiotherapy possible to patients for whom head and neck cancer represents a life-altering diagnosis, in every nation in which they seek care. Proton therapy advancements for head and neck cancer. References: Alberta Health Services. 2023, Proton Beam Radiation Therapy Clinical Practice Guideline. RT002, Effective Date, October 2023. https://www.albertahealthservices.ca/assets/info/hp-cancer/if-hp-guide-rt002- Proton Beam RT.pdf. ASCO Post. 2025, November 10. Intensity Modulated Radiation Therapy vs Proton Therapy for oropharyngeal cancer. The ASCO Post. https://ascopost.com/issue/november-10-2025/intensity-modulated-radiation-therapy-vs- Proton Therapy for Oropharyngeal Cancer. Bala, K., Samovich, Y., and Dorobis, K., 2024. Proton Therapy in the Treatment of Head and Neck Cancers, Review. Current Oncology Reports, 26, 11, 1380-1387. https://doi.org/10.007/S11912-024-01592-9. Bridging the Proton Gap, a proton therapy consultation service for Canadian radiation oncologists. 2025, PMC/PubMed Central. https://pmc.ncbi.nlm.nih.gov/article/pmc122057771. Canadian Medical Association Journal. 2019, Proton Beam Therapy for Cancer. CMAJ, 191, 24. E664, E666. https://www.cmaj.ca/content/191/24/E664. Chen, Y.H., Croezen, M., Hugeman, M., Versteeg, M., Boldegrote, C., and Blomestein, H. M., 2025. Treatment-related toxicity, utility, and patient-reported outcomes of head and neck cancer patients treated with proton therapy, a longitudinal study. Clinical and Translational Radiation Oncology. https://doi.org/10.1016/j.tro.2025.100913 Proton Therapy Advancements for Head and Neck Cancer. Frank, S.J., Busey, P., Rosenthal, D.I., ETAL, 2024. Phase 3 Randomized Trial of Intensity Modulated proton therapy versus intensity modulated photon therapy for the treatment of head and neck oropharyngeal carcinoma. Presented at 2024 ASCO annual meeting. Abstract 6006. University of Texas MD Anderson Cancer Center. https://www.mdanderson.org/newsroom/ASCO-hyphen-therapy-demonstrates-advantages-. In Phase 3 Head A.00-1596983334.html. Goreski, P., and Saran, F., 2024. Transforming Cancer Care in Australia, The Dawn of Particle Therapy. Journal of Medical Radiation Sciences, 71, Supple 2, 3-5. https://doi.org/10.1002/jmrs.784. Kiev, P., ETAL, 2024. Photon versus proton radiation therapy in head and neck cancer, a review of dosimetric advantages and patient quality of life. Journal of Cancer Metastasis and Treatment, 10/31. https://doi.org/10.20517/2394-4722.2024.79. Lee, A., Woods, R., Mahfouz, A., Kitpanit, S., Cartano, O., Mohammed, N., Youssef, I. Lee. N.Y., 2023. Evaluation of proton therapy reirradiation for patients with recurrent head and neck squamous cell carcinoma. JAMA Network Open, 6, 1, E2250607. https://doi.org/10.1001/JAMA-networkopen.2022.506007. Lillo, S., Mirandola, A., Vi, A., Camarda, A. M., Ronchi, S., Bonera, M., Ingargiola, R. Viscioni, B., and Orlandi, E., 2024. Current status and future directions of proton therapy for head and neck carcinoma. Cancers, 16, 11, 2085. https://doi.org/10.3390/cancers16112085. MD Anderson Cancer Center. 2025, December 11. Proton therapy shows survival benefit in Phase 3 trial for patients with head and neck cancers. UTMD Anderson Newsroom. Proton therapy advancements for head and neck cancer. https://www.mdanderson.org/newsroom/research-newsroom/proton-therapy-shows-. Survival benefit in Phase 3 trial. H00-15978198.html. Nature/British Dental Journal. 2022, Recent Advances in the Oncological Management of Head and Neck Cancer and Implications for Oral Toxicity. British Dental Journal. https://doi.org/1038/S41415-022-51955-5. Nudes, S., Balin, H., Ng, SP, Corey, J., Esbruch, A., Mendenhall, W.M., SME, R., Strojan, P., Ng, W.T., and Furlato, A., 2022. Proton therapy for squamous cell carcinoma of the head and neck, early clinical experience and current challenges. Cancers, 14, 11, 2587. https://doi.org/10.3390/cancers14112587. Past, present, and future of proton therapy for head and neck cancer. 2020, Oral Oncology. https://doi.org/10.1016/j.oraloncology.2020.104703